another distant site. Some people actually, there are contracts for telepsychiatry where they're actually doing consultation to emergency rooms. So there's lots of different ways in which we're providing telehealth care, and depending on the setting, that certainly has a bearing on the sorts of resources we have, the sorts of opportunities we have for safety, et cetera. So I wanted to just clarify that from the start. And as Michaela said, this is a grant through, actually it's through SAMSA. There are a number of technology transfer centers around the country, and our current one that we belong to is the Mountain Plains. In addition to mental health technology transfer centers, there are addiction, there are prevention, there are geriatrics, there are lots of different types of platforms that we utilized in training. So a disclaimer, even though it's sponsored by those entities, it's important that people know that this is my presentation and not necessarily representative of those sponsoring entities. We would ask that you, at the end of this, you do an evaluation. And it's important for, since this is actually a grant from the federal government, they want to know, did people actually attend? Was it valuable? Was it not, et cetera? And so that's very helpful, not only for us in feedback, but also going forward. If these sorts of presentation are felt to be beneficial, then there's opportunities for additional grants down the road. So the objectives are defining concepts associated with suicidality, that term, talking about potential risks and assessment when we're doing telehealth versus in person, talking about risk factors, protective factors, et cetera, as far as suicide. We'll talk about screening tools, referral process, and then resources that you might want to link up with. So when we talk about suicidality, suicide itself is defined as death caused by self-directed injurious behavior with the intent to die as a result of that behavior. So we all know of situations where someone accidentally had a death by suicide. Oftentimes that might be an overdose. Sometimes it's, thinking that they were wanting to relieve some pain, but not going so far as, truly being suicidal, and then there are accidents. So it's really the intention as a result of the behavior. An attempt is non-fatal, self-directed, potentially injurious, with an intent to die as a result of the behavior again. So a suicide attempt might not result in injury, and injuries might not be suicidal. And so, some of the things that we talk about, we all know that there are individuals who do cutting for relieving distress and pain, emotional pain, et cetera. And there can be some overlap there. And then ideation refers to thinking about, considering, or planning suicide. So there are lots of different terms there. And when we talk about a completed suicide, more recently, there's been a request to use the term, the individual died by suicide, as opposed to committed suicide. Many people in the midst of this impulsive act really did not have a long-term intent of, ending their lives. They wanted to end the pain. They didn't necessarily plan this out. And so it's a more humane term to say they died by suicide. So looking at some of the demographics, the data from 2018, we see that young people have significant suicidal thoughts. This isn't color coded, so it's a little bit different. There are shades of gray to black. But we also know that there are deaths by suicide, completions within that population. There actually have been rises in the middle age groups. And also we know that there are particular populations such as the very elderly with significant losses, chronic disease, chronic pain, who are also at significant risk. When I first got out of psychiatry residency, my first job was doing outreach to the elderly at risk. And I remember sitting on the couch in this gentleman's home with the case manager, and asking him, screening for suicide. And he was an individual who had he was a widower, he had chronic pain, depression. I asked him, the typical questions, and finally asked him, so do you own a gun? And he said, yes. And I said, is it loaded? And he said, yes. And I said, where is it? And he said, you're sitting on it. And literally I was sitting on the couch on his loaded gun. So there are certainly risks to us and some benefits of actually doing it via telehealth versus in person. So by age, there are a couple of things here that are notable. One is certainly in the past decade, there has been a consistent rise in suicide. And also what we're seeing is the middle-aged group is actually leading that. There's a significant rise among youth and a steady rise among the other populations. So there's been lots of discussions about what is the cause of the increase in suicide rates. And that's probably for another time and another discussion. We know also that it does vary from culture to culture, race to race. There are many issues that go along with that. We know that historically, Alaskan Natives, American Indians are a high-risk group from a general population, both in terms of suicidality and also the attempts. We know that that can vary across populations, but it's always important to look at the individual. And so having a sense of culture certainly is beneficial. Knowing what the social determinants which may be contributing to the risk or protective factors is important. But everything is individually based as well. And this is just another slide and reminder of those high levels and high incidences across certain cultural and ethnic populations. In terms of methods, firearms, and this is 5 years old, firearms contribute to half of completed suicides. Suffocation, hanging, asphyxiation is next. Overdoses, poisoning, it could be carbon monoxide, could be medications, could be drugs, illicit drugs, and then others. So when we think about doing an assessment, particularly by telehealth, we want to know where the individual is located. We want to be identifying where we are. We want to have a good grasp of what the individual's needs are. And as many of you know who are doing this type of work, sometimes we know ahead of time what the risks are. We have a good indication of who the person is, why they're coming to see us via telehealth. Other times it's kind of a surprise out of the blue. You are seeing somebody with really acute suicidality. Making sure that they're aware of what their rights are, what the treatment plan is, knowing what the environment is in which they are seeing us. If there are any other issues in terms of collaboration, was this a referral to you? Are there other people involved both geographically at that location or in the area, or what are the considerations of others involved? And do we have the necessary information? And again, this is a tricky thing with telepsychiatry, telemental health. Sometimes we have access to all the information that we need. Other times it may be forthcoming and we don't have it available to make the determination we need. And then we have to do the best that we can and document that. But it's, can we line up as much information as we need to make a good standard of care type of decision? Safety and emergency management is obviously huge. We want to know what resources are available at the originating site, which is where the client or patient is at, what support systems are in place, what access they have, both to resources protectively, but also in terms of risk. And I also mentioned previously just cultural competency. So just a reminder again, and this seems somewhat counterintuitive, but the originating site is where the individual, the patient or client is at. Distant site is where we are at. And so again, some of us may be doing, may have our distant site from our homes. It may be from our offices. It may be from somewhere else. The originating site may be in another treatment facility or clinic. It may be the ER, it may be the patient's home, the client's home. And so we always want to know as much information as we can about that as we're building our safety plan. And some of the other challenges, so in telehealth, is missing communication nuances. So some people really miss being close up enough, to be able to really see the facial changes, to have a good sense of changes in intonation or movements, et cetera. And you don't always have that with telehealth. So telehealth is typically the next best thing for most people, but oftentimes people who rely on their own ability to look for those nuances, sometimes that can be difficult with telehealth. Oftentimes it depends on what type of hardware you have, what type of platform you're using, what type of camera you have, what's on the originating site, et cetera. Another, as I already mentioned, was the data. And some of that can be hard copy, some of it can be electronic, some of it can be actually collateral information. And then sometimes we just don't have the resources for safety and expediency. So if we know ahead of time, one of the things that we want to do is this a safe enough situation for me to do an evaluation? If it's not, then what are the options for the individual and whomever may be making that referral otherwise? Or is this, we recognize the shortcoming, but this is the best we can do for the time being, and we need to try to come up with an expedient plan. But those are the challenges that we oftentimes are dealing with. And so before the encounter, we want to have as much information as we can to try to make a determination of the safety needs. And sometimes that's a determination whether or not this is a good idea to do this by telehealth. Others, it's just teeing it up and waiting and trying to plan for what might occur in terms of the assessment and the need for a more emergent type of action. And then the necessary records. So some of us are adept and have electronic medical records. Others we don't. I know that when I've done telepsychiatry before, for other agencies, I've sometimes had to rely on staff to scan and send me information that might not otherwise be available, et cetera. So as I mentioned in a previous discussion on ethics, is we also want to know what we are missing, and so and be aware of that and be able to follow that up later, or for sure to be able to document when we were making our decisions, what did we have available, what were we unable to have available, and how that might have made a difference. And then, backup phone numbers, backup names. We don't always think about that from the start, and we don't want to be off-putting to people saying, I need this and this and this and this, as we're trying to engage and develop a relationship. But there have been a number of times where I've said to an individual, look, it's not unusual to have your internet drop, or for something to happen where we can't do this by a video conference anymore, but I could call you or I could reach you in other ways. So can I have your phone number in case this happens to drop? Or is there another individual that I can contact if we have trouble here? So setting that up ahead of time is actually quite helpful. There have even been times where I've said to a patient who has been at another facility that I may not be necessarily that well acquainted with, I've said, there's a phone in that office there. Can you tell me the number so that if this drops, I can contact you? And I've had that happen more than once. So we just need to know, particularly with telemental health, we need to be prepared that things will not go as planned. We need to be able to be flexible and to be able to multitask. And so that's one of the challenges of telemental health. One of my favorite stories was I was seeing an individual 300 miles away who happened to be in another clinic setting. That person happened to be have bipolar disorder, manic depression, was floridly manic, was changing things on the video conference television set and the monitor and the sound. And behind me, our fire alarm was going off and it was just chaos, but we managed. I was able to contact the nurse who happened to be in the room next door, and we talked back and forth, and things were okay. But if you're planning that things will be smooth, that is usually the exception, not the rule. So, we want to be able to build trust and establish rapport. And that particularly that's really a gift in terms of developing skills with telemental health. It's not natural for us to be staring into a camera on a monitor. We want to be reading, we want to be doing our notes, we want to be doing other things. And so, developing a relationship is really challenging via telehealth. And like I said, many of us would want to be able to use those nuances in reading people's facial expressions and having a better sense of engagement, and that can oftentimes be a challenge. So we want to make sure that despite our assumption that we're coming across okay, we might want to ask even more questions about, did you hear me okay? Can you repeat back what I'd mentioned to you, so I can be sure that I'm getting my thoughts and recommendations across. And so active listening, specific questions, and you all know that, but it's a useful reminder. And then the other thing about this is, if you have the opportunity to have someone else record you doing a session or watch you and give you tips, that can actually be quite helpful. Again, most of us, are not that adept at this, and particularly people of a certain age who did not grow up with technology like this, it's more of a challenge. I'm a person who happened to grow up in a country doctor's home with a party line, and so this does not come naturally to most of us. So it's like everything else, it's a skill that needs to be learned. So when we talk about the assessments, and screening. So there's a difference between screening and assessment. So screening is really just throwing it out there, checking. An assessment is more, the moving towards an evaluation. And so many of the things we're talking about, particularly in primary care settings, emergency rooms, et cetera, a lot of that is actually screening to start. And the tools that we're using are not for diagnoses, they are for screening for certain risks and conditions. So Zero Suicide is a project that you may have heard of as we talk about resources. And so, this is a nice diagram where we're looking at, a person who may be suicidal, doing some screening, making sure that we're checking for a safety plan, treating the suicidality depending on the risk level. And then what is the follow-up? And so for some individuals, they will be ongoing clients of ours. For others, someone else may be responsible for that. And it's important to document what the plan is. And then the question is, okay, so if somebody said they would do these things and their family was there to support, who's going to know if they followed through or not? And so oftentimes I'll talk with staff about, if we referred, did they show up for the appointment? I'd like to know that. And from a HIPAA standpoint, that's fair game to ask and to check. And so we want to not just drop it. We want to follow up when we've identified some risk. It may or may not be our responsibility, but we want to make sure that people have had the opportunity to follow through. And so, and as we're talking about our doing assessments, we also recognize that, most of us on this call are mental health professionals, but some are not. And so there's been a real effort over the past few years to train non-mental health professionals and actually non-providers, including people like teachers, first responders, people in the faith community, others that may come in contact with someone, and it wouldn't necessarily be their role to be a mental health professional, nor should they be, but they can learn to do the screening tools when they have some concerns or suspicions. And so you all know this, but asking a depressed person about suicide does not make that worse. And so we know that we capture a lot of people who are at risk by doing that. There's also the assumption that nobody's going to tell you. You know, I think for those people who have a relationship where you are stopping them from doing something that they have a real high intention of doing, and this has been a concern for some time, that may be true, but one shouldn't just default and say, well, they're going to do it anyway. For most people who have suicide attempts, it is impulsive. There's a window of time, and our job is to try to, you know, identify that and help them stay safe until that time passes. And then the other myth is, you know, if they make threats, that they're just looking for attention. You know, that rarely is true, but even individuals who have a high incidence of, quote, gestures or acting out, they are also a much higher risk for completed suicides. And so that's why, again, every one of those incidences is important to assess on its own merit. So somebody 2 weeks ago, it may very well have been unintentional and perhaps even for some intention, but today that might have changed completely. And where we find people having trouble is when they have this blanket thought about an individual and say, you know, they're just doing this for attention. We really have to take each case specifically. So another tool, the Lighthouse Project, it's a really good website. And when I was talking about training teachers and coaches and first responders, et cetera, they have a multitude of tabs on their website for specific populations of providers or non-providers. Yeah, and they try to tailor that to, you know, that group's needs. But their screening tool looks at asking 3 questions for sure. And as you can see, have you wished you were dead or wished you could go to sleep and not wake up? So essentially, you know, those are the passive resignation sorts of thoughts. Oh, if I died in my sleep, I wouldn't mind. Or, you know, if I had cancer and this overtook me, I wouldn't mind. And yes or no. And so they also have had areas within there that you can ask in the past month. Some ask the past week, some have asked the past 3 months, but you know, you pick a time. And then have you actually had any thoughts about killing yourself? So if question number 2 is yes, then you go through the entire 6 questions. If the first 2 are no, you still want to ask the last question, question number 6. Have you ever done anything? And the reason for that is, even though they're not suicidal today, if you find out that, yeah, oh, by the way, I did this when I found out that my girlfriend was going to leave me, and your discussion is you're hearing things about the relationship that are not very good, that's important information to know. So again, in the Columbia Protocol, they ask, you know, any thoughts passively, any thoughts, you know, more actually about killing yourself. And then regardless, going through number 6. And then 3, 4, and 5, the risk increases over time. Clearly, have you started to work out or work the details out of how you plan to kill yourself, et cetera? How do you intend to do that? How do you intend to carry that out? So we know that those are significantly higher and more imminent risks. There's another screening tool that's called the safety, and I know this is a busy slide, but essentially it's identifying risk factors, protective factors, and we'll talk a little bit more about that. You know, asking about suicidality, figuring out what your sense is of the risk, and then documentation. So risk factors, and we'll spend a little bit more time talking about this, but obviously past behavior, current concerns, do they have a psychiatric disorder or psychiatric concern, which increases their risk, and things such as, you know, hopelessness, helplessness, significant anxiety, long-term struggle sleeping. So this is kind of a hallmark. There's certainly a higher risk for suicide of people who are having significant sleep problems. Now, during COVID, who doesn't have sleep problems? And so you don't want to say, oh, everybody who's having insomnia is suicidal. But retrospectively, when we look back at people who have had attempts, some of those with severe insomnia, and even some with just significant dreams, along with their anxiety and depression, may actually be a higher risk category. And then so, family history is important in terms of suicide. There are some families it clusters, and that's important information to know. Precipitants, and this is the difficulty that we see, particularly in terms of impulsivity. Somebody gets arrested and they're shamed because they got a DUI and they have, a position in society in which they just can't see themselves living with that. I had a physician colleague whose son died by suicide when he got a phone call with his girlfriend wanting to break up. Very impulsive, parents weren't home, and that was that. So these precipitants and stressors are certainly important. And the other thing, as I mentioned, is, are there things that may not be happening right now, but are foreseeable within our conversation with the client or the patient? Protective factors, their own coping skills, religious beliefs, how they manage stress, are they self-soothers? Do they have the inability to self-soothe? What are their responsibilities? Who are they engaged with in terms of relationships, social supports? And then, as I mentioned, talking about suicide. And, we have some clients or patients who it seems like they are chronically suicidal, and that certainly can happen. But for those individuals as well, there are moments in time where that risk is heightened. And again, we don't want to just make the assumption, oh, they're always chronically suicidal, or they're wanting attention. So again, in our assessments, what is different, if anything? What their plans are, the behaviors, et cetera, we talked about that. Do they believe that what they're talking about for suicide is actually going to, excuse me, get the job done, despite our knowledge that this won't happen? If it was their intent, then that's being suicidal. And then, the risk levels, interventions. And when we looked at risk factors before and above there's access to firearms. What is their access? And so we do our best in terms of assessing risk level, and you can see that last table down there. If somebody has command hallucinations, if they are on street drugs and they're having command hallucinations telling them to do something harmful to themselves or others, that's a significant risk. Other people who may have schizophrenia, who aren't necessarily depressed and they're having hallucinations, but they actually are what we would call egosyntonic. They're helpful, they're pleasurable, etc. That's a completely different issue. So not everyone with hallucinations, has suicide risk. And so those possible interventions they talk about, if they're high risk, potentially lethal suicide attempt, how can we get them to safety? And we'll talk about that again in terms of telehealth. The moderate risk, that's that fine line. And as clinicians, that's what we oftentimes struggle with and wonder on the weekend if the individual that we made a plan with and said they were going to be okay are actually okay. And then there's the lower risk, which is fortunately easier. So as we're talking about, primary care in particular, or the emergency room, so many of us have colleagues that we work with or consult with that are in primary care. And we also know that 30% of individuals who died by suicide saw their provider within the last week, which is kind of frightening. And some of those may not have been forthcoming. Others we may not have screened well, which is why we're seeing more and more routine screening, which we'll talk about. Half of those individuals within the last month. And so the screening that we're talking about doing, and primarily it's the PHQ-9, which is the most common, is something that has been occurring on a regular basis. And I'm sure that many of you have been involved in that. And so this is an example of the PHQ-9. So essentially going through the standard questions for DSM for depression. So little interest or pleasure, anhedonia, feeling depressed or hopeless, and then some of the vegetative symptoms, fatigue, sleep, appetite, energy, and then the cognitive sorts of things, feeling bad about yourself, concentration, or the negative ruminations, etc. Now, it's always important for those of you who use the PHQ-9 or know individuals who are using it. The risk, particularly with electronic records or flags of scores, is that it would be really unusual, but it's possible that somebody could score a 3, which most cutoffs would say, well, not a problem at all. But as you look at this, somebody could score, I have little interest or pleasure in doing things several days out of the week, which is a 1. And question 9, which is the suicide question, score a 2, more than half the days, I'm feeling suicidal without necessarily some of those other vegetative symptoms. And so somebody could still be suicidal and yet, not reach that threshold. So it's always important if you say PHQ-9 was this score, that you looked at question 9. Also for youth, so there's something called the ASQ, which is, it's approved for kids 8 years and older to do screening for youth. And I didn't add the second slide to what I'd sent to Michaela, but I will do so. So this more than doubled the detection of suicide risk compared to treatment as usual in emergency departments. And so these are the questions on the ASQ. Pretty straightforward, asking about suicidality. And then again, just like the Columbia, just like the safety, it gives recommendations for next steps. So this can be really confusing there's so many tools out there. So your own organization may have a requirement or recommendation. You may, if not, you can certainly choose your own tool that you're comfortable with and utilize and get to know well. So again, protective factors, risk factors. Static are those are going to be unchanged. You can't undo the past. And so you can't undo prior attempts, but that's important to know. You can't undo a relative's completed suicide. Individuals with chronic pain or conditions that aren't going to significantly change are all static risk factors. Those are things that may not change. The dynamic ones can change. And so people with significant anxiety, which is a risk, anxiety can be brought down. Hopelessness, hope can increase. Command hallucinations can be treated. Impulsiveness, aggression, severe insomnia, degree of suicidality, their plan, access to means, lethality, intent, all of those things can change. So there are some risk factors that are essentially stable, not good, but stable, static. And then there are others that we really try to target and make a difference in. So protective factors, people who are employed. And so we'll talk a little bit too about COVID and some of the impacts on people with COVID. So employment, you hear the stats that, well, with every 1% of unemployment, there's an increase in 1% suicide. That really varies. And it varies within communities depending, or countries, regions, depending on the level of chronic unemployment, or if it's rather abrupt and short-term unemployment. So if people are certain that their job will return, that it's protected, even though they're not currently employed, then that actually is a less risk. Doesn't mean it's not nothing, because certainly the financial impacts are a concern. But when you think about, do people have their jobs protected even though they're furloughed, et cetera, those sorts of things are protective factors. Religious belief can be a protective factor, but It's not a guarantee. Other reasons to live, I have responsibilities, I have children in the home, I'd never do that to them, et cetera, et cetera. Those are protective factors, but again, we really want to do our job in terms of really doing a good assessment. Psychosocial supports, are you alone? Are you lonesome? Or do you have other people that can assist you? And then, as we mentioned, there are some people that are just better adept at managing stress, at not becoming more ruminative, negative, et cetera. So I caution people, we see this all the time, and certainly I have done it in the past, and I'm sure you have too, but we want to be cautious when we document that individual contracted for safety. It's okay to write that if you've also documented everything else that you've addressed in terms of those risks. But you don't want to depend on an individual saying, I'll be okay, because clearly there are times where they cognitively can't make a good faith statement. They're actually so depressed or so disturbed. And so I would caution you about relying on that alone, because you really have to have other supporting documentation. And then we also want to know, as I mentioned before, particularly if we're referring to other people, but also for our own patients, we're assuming that we have a good safety plan in place. But if this changes, so, Bill has broken up 3 times with his girlfriend, and now his girlfriend says it's fine, and we work things out, and we've given Bill the the phone number to call, et cetera. But what would you do if this happens again? And what's the actual likelihood that over the next few days, this risk factor is going to occur again? We want to think through that and know that, again, we want to think about foreseeable risk and have that weigh into our decision-making and our documentation. So if we're doing telehealth, how do we intervene if somebody is a more imminent concern? So if we have at the start, gotten some of the contact information, particularly if the individual isn't being seen in a clinic or some other place, who are the support people that we can contact right away? If there are not, are you fortunate enough in the areas that we're talking about where there's a community mobile crisis team? Most of us, we're talking, rural areas, and so many times there aren't. Some places do. There's always law enforcement and, ambulance, 911, et cetera. So we want to do the best we can. And so again, that begs the question of, was this a reasonable thing to do this assessment? Oftentimes, like I said, we're the only game in town, or this is the only opportunity to try to do this assessment, but we have to be able to plan for how are we going to intervene. And so these are some of the ways in which we would do that. And then as you're, so if we decide this isn't imminent, but there are maybe concerns, how is follow-up going to occur? Who does the scheduling? One of the things that we've seen with COVID is that sometimes the providers, like physicians, who are not very good at scheduling, are the ones that are doing the scheduling. And so, particularly at a time when individuals weren't coming in for schedules, or support staff were maybe furloughed, et cetera, we want to know, how is this going to be scheduled? Or if we can't schedule you today, I want you to call in, make the appointment, and make sure that you follow up. So we want to make sure that we're documenting that and not just dropping it. We also want to know, to hopefully have clients know that, especially if they're coming in to a facility. So if they're coming into a clinic or coming into the ER or whatever, and they're going to see a provider who's 300 miles away, we want them to know that information as soon as we can. I've only had one particular patient that I can think of who just absolutely refused to see me by telemedicine once he found that out coming into the clinic. But otherwise, most people tolerate that well. But just in terms of informed consent, you're going to see this individual on the screen, et cetera, et cetera. And then at the end of the encounter, if we have other directions, how are we going to provide that? Is it going to be electronic? Is it going to be simply I will mail it to you. Is it going to be, will you look this up, etc. So again, you know, when we're looking at risk and we're looking at lethality, you know, many of the individuals in our region have firearms. They're hunters, you know, and so we always want to take that into consideration. You know, are the guns locked up? Who has the key? Is it separate from the ammunition? Even situations where somebody previously has had overdose, you know, attempts, and this time they say no, but we know that there may be some risk in the next week or two, depending on what they told us. Did they get 3 months supply of their medications? And if so, you know, can they have a family member help them to put that away, et cetera? So we want to be thinking ahead in terms of what are the means, what are the potential concerns, and how can we mitigate that, while at the same time, you know, respecting their individual rights. And so that's that boundary between, you know, professionals, you know, using either commitment rules, alternative treatment orders, et cetera. And it can sometimes be a fine line. So with COVID, we've certainly seen an uptick in various types of stress and distress, and I don't need to tell you that. We've all experienced that. Clients have, providers have, et cetera. Interestingly, there's been different data on suicidality. Some have said, actually, there hasn't been a significant increase. Some of it, I think, is more regional. Some of it, like I said, depends on what the plans have been in place in terms of employment, et cetera. So that has varied. There certainly have been increases in trauma, including domestic violence. There's certainly been increases in substance use. And so all of those things can also add to the risks of further harm to people. And that's what we've been seeing with COVID. Whenever there's an emergency declaration in disasters, as there has been also with this pandemic, there are government contracts that go out to states, usually by the state mental health authority, the commission, with contracts to other providers to have psychological first aid as one, or mental health first aid, but crisis counseling. And so right now, some of you may be involved actually in crisis counseling contracts through SAMSA or HRSA for individuals at risk of mental health issues due to COVID. And so these are, you know, immediate supports, community-based outreach, psychoeducation, which is a challenge now with telehealth. The last time I was involved in this before the pandemic, it was during floods, and you could go out to the population and you could, you know, knock on doors and check with people and see, you know, what the needs were. With telehealth, it's been different. Critical incident stress debriefing, you know, that's really only intended for specific groups, and it's controversial because, you know, people really need to know what they're doing. So for our first responders or tight units, you know, military, et cetera, National Guard, that can be very effective. But you don't want to do critical incident stress debriefing on the general population. So that's different than helping people debrief a little bit, but you need to know what you're doing when you're doing debriefing. And that's for another talk as well. So what about non-urgent or emergent resources in the time of COVID? People can still do things virtually. You can do one-on-one therapy. You can do virtual group therapy. There are lots of support groups out there that there are non-professionally, you know, based or led. There are plenty of apps out there. There are lots of apps on meditation, on relaxation, family, friends, others, you know, healthy habits in general, looking at your sleep, looking at your exercise, your nutrition, et cetera. So there are lots of things that we can prescribe for people that aren't costly. And then lastly, so I mentioned there's the Zero Suicide Project, there's assist training. There are lots of training programs in terms of helping communities reduce suicide risk. The Suicide Prevention Lifeline, though, the Suicide Prevention Resource Center is a great you know, resource and page for lots of different programs, lots of different ideas. And as I mentioned, also, you know, the Lighthouse Project, the safety plan. There are many different things that you can look at and become comfortable with for your toolkit. And that's really all I had at this point. So we'll go ahead and stop and ask for any questions.
It looks like there is a question in the chat that says, can you repeat, how did you put that for every 1% change in employment?
Yep. Yeah. So there's been this data that's been supported in other studies that, particularly when they were looking at economies shutting down, and they've looked at other crisis times where they found that for every 1% reduction in employment, there was a 1% increase in suicide per population. But I caution people about just that blanket statement, because it really does vary depending on the economic supports that are in place. So, there is data out there, and we know that reduction in employment can increase stress, it can increase suicidality, but it's not a, it's not a given with those ratios. It does depend on what the community, what the state, what the government and other privates are doing in terms of supports for people, and are they going to have their job in the near future. And so you can have discussions about unions, you can have discussions about furloughs, and so that all comes into play. So that was part of what I was intending. Any other comments or questions?
There was another one that came in on the...
Yeah, somebody was driving. Well, hopefully you're driving safely. And so was that the immediate threat? Okay, what's the best way to handle an immediate threat while on telehealth with the client? Well, one of the questions is, and if you've been around long enough, you've probably experienced this. If you were doing telehealth and there was somebody else available, you could sometimes signal to them to contact emergency services where the individual is and keep the person on the line. If you don't have that availability, then you still would need, if you can access somebody, whether you're, so if you're on a computer or you're on a phone and you don't have anybody else around, you could perhaps instant message another individual or email a friend or something like that to try to alert them. But but if you're not able to do that in real time, then certainly just contacting 911 or the emergency services as soon as you're off the call. Obviously, we want to keep people on the call as long as we can, and then try to access someone else to assist us in getting help. But that again is why it's really useful to try to prepare ahead of time and get as much collateral information as we can and supports, so that if that happens, there are people, in real time that we can contact. If not, the default is, 911. There are certainly times where, and it may or may not be successful, where you need to say, I need to pause for a second, and you could call 911. They may or may not stay on the line, or stay with the video conference, but you do the best you can in the circumstances. And again, pre-planning is best. Doesn't always work out. They're not always available either, but you always have 911 also. I don't know. Do other people have thoughts about that? I can tell you that, and so this is another point. It can feel pretty lonely when we're dealing with these significant crises with high risk. And so in my previous presentation, the number one thing I learned in residency was expand the field. So whenever you're feeling stuck, you do what you need to do. If it's in real time and you're able to do that, great. I used to actually have, when I was seeing acutely suicidal patients and I wasn't comfortable with my decision, I would actually ask other staff to come in. And they were, they weren't psychiatrists, but they were very adept and very, seasoned people who could help me walk through. In telehealth, we don't always have that option, obviously. But if we can't contact somebody in real time during the call, we can certainly do that right after. Yeah, when the safety plan isn't working, and that's again, some people have expected, well, this is great, this telehealth is wonderful, and for a lot of people it is, but boy, the unexpected will occur, and you just need to be comfortable with that and prepared for that. So will this presentation and handouts be available for review? That should be, Michaela should have that. And Michaela, what I will do is actually, I'll send you the PDF of my talk, which is much more palatable than a huge slideshow. So that would probably be better for the audience. But as Michaela says, they'll be on the website. And I don't think, what would you recommend doing a conference call with a person in line to 911, or is it best to hang up and call? That's a great question. For a lot of people, if I know that they are just going to run, that's probably not going to work. But for a lot of people, I've been able to say, look, I'm really concerned about you, but I'm feeling stuck here. And I'd like to reach out to somebody else and help you process this, because this seems emergent to me. And so would you be okay if we went ahead and did that? And so I would certainly, if the opportunity was there to conference in, absolutely, I would try to do that. I've had times where people have just taken off and run. I've had other times where they've tolerated that. I think most people would appreciate the concern and the effort, but you just do the best you can. So certainly that is an option. National Suicide Hotline coming into play 988. I'm not sure when that's going to occur. I think the first of the year, but there are lots of crisis lines out there. And actually the Suicide Hotline does also have a text, and there is the crisis text line that's mentioned here too. So, which is a really good point. Some people just aren't comfortable talking. And so there are opportunities actually for text as well. I know that usually if you're around other staff, they can call 911. That's true. Yep. Yeah. And so if you're in a situation where, that is available, and sometimes you have to do it kind of undercover. Other times you can just honestly say, man, I'm really stuck here, and I need some help in terms of how I'm trying to make decisions to help you. And so I want to just drop out and talk to one of my colleagues real quick. If it's safe for you to do that, go ahead and do that. If you're afraid that that's going to cause the person to drop the call, then if you have the ability to do instant messaging or other sorts of things within your system, that's one good tool to use. Should you ask the client's location at the beginning of every session? Yeah, actually you should. That's actually one of the requirements for reimbursement. Is you're supposed to be able to know where the person is, particularly if you're not licensed to see the person in that state, then that can be a concern as well. So yeah, you want to know, because it certainly isn't apparent always. And I have colleagues who have been doing telehealth from their trailer in Florida, and the client wouldn't necessarily know that either. So it's always important to tell people where you are and to find out where they are. Let's see, example of flexibility you mentioned before. Well, I think in particular, we grew up in mental health having a set way of doing evaluations. And so again, if you work with kids, then that's going to be disrupted. Or if you work with really seriously ill people, that's going to be disrupted. So when I'm talking about flexibility, just be ready to roll. I mean, you just need to do the best you can with what you have, because things will happen. Calls will drop. Your dog will come across the screen and be disrupted. There are lots of things that will occur in telehealth that can be disruptive. And so people who like things just so, and for things to go perfectly, this is a tough venue to use, I think. So, okay, this says got an email 998 isn't going into effect until 2022. Good to know. Things may change, but yeah, SAMSA has a crisis line in Spanish. There are actually lots of different languages. that are available as well. If you know ahead of time, a person may have a language issue, you can actually call there are contracts that are available usually with lots of organizations and actually requirements in the person's own preferred language. Urgent versus emergent. Boy, we've got 3 minutes left, and that's for another. I think if you look at those tables, it explains pretty well, you know, what imminent is emergent. Urgent means it means to be addressed and looked at, but it might not necessarily need to be dealt with a higher level of care, et cetera, but it shouldn't be dropped or ignored. And so, you know, urgent would be, yeah, somebody has suicidality. They've had plans in the past. There needs to be some assessment by somebody who knows what they're doing to ask more questions. And for some people, given safety issues, you know, that's okay within, you know, a day or so. For others, no, it actually has to be ascertained today. So those are those. The urgent needs to be looked at, may need to be looked at immediately, may be able to wait 2 or 3 days if the risks aren't going to increase. And so there are probably a lot of examples there for that. The bill to have a direct line for suicidal risk colors, 366. How long to receive their certificate? Don't know about that. So we are coming up to the end. I'll make sure that Michaela gets the most recent PDF. And thanks everybody for joining. Have a good day.
Yep. Thank you.